So good afternoon, everyone, and thank you for joining us for the second session of the 2021 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center, a HRSA-funded geriatric workforce enhancement program at the University of Rochester, the Western New York Rural Area Health Education Center, and the Monroe County Department of Public Health. My name is Laura Robinson, and I am the program coordinator for the FLGEC. We are very glad you could join us here today. So a few housekeeping issues before we begin. There are two important buttons on your Zoom toolbar. Please use the chat button that will allow you to type hello and introduce yourself with a name, job title, agency, and location. And we have people from across the country joining us today. The Q&A button will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question so that the question does not get lost in chat. And we will address all the questions at the end of the session. Now I will introduce our sponsors. The Finger Lakes Geriatric Education Center has been continuously funded by HRSA since 1999. We currently serve a 25-county area of the Finger Lakes region, but truly serve all of New York State through collaborations with many academic and community-based partners. Through educational initiatives targeting all healthcare providers and family caregivers, the goal of the FLGEC is to transform clinical training environments by integrating geriatrics into primary care delivery systems, resulting in an age-friendly health system as well as dementia-friendly communities. And my dog says hello. I apologize. She's not really saying hello. She's guarding us. And the Western New York Rural Area Health Education Center is a nonprofit organization headquartered in Warsaw, New York, serving 12 counties. The Rural AHEC's mission is to improve health and healthcare through education. The Rural AHEC also addresses the health needs of its communities by focusing on health workforce development, preceptor development and student housing, pipeline programming, and rural healthcare technology infrastructure development. The Monroe County Department of Public Health has a long history of collaboration with the University of Rochester and the FLGEC. The Monroe County Department of Public Health provides direct public health services designed to protect the public from disease and environmental hazards, and community leadership to ensure improved health status of individuals, families, and the environment. Their services include education, prevention services, and enforcement of health codes and medical policies. Now, I just want to walk you through these disclosure slides about our program today because we are certified to offer CME credits for healthcare providers and social work credits. So the planning committee and the presenter have no declaration for financial disclosures to tell you about. And these are our accreditation statements. Following the program today, I will email you a link to our CME tracker site, which will allow you to log in with the same email that you used to register and obtain your credits. I do have to compile the attendance for today's session. So please, again, introduce yourself in chat. That makes my job of putting the attendance together much easier. So say hello, tell me your name in chat because sometimes people's usernames do not match their real names. And so you will receive one AMA PRA credit, Category 1 credit for CME or 1 credit for social work. Now I will stop sharing my slides and ask Lisa to please share her slides. And I will take a moment to introduce her. So Lisa Nolan is our speaker today. She is the Director of Education and Training at Willow Domestic Violence Center. Lisa has been part of the Willow team for nearly 2 years, coming from a role working in higher education with college students for 14 years. Lisa's time in higher education was primarily spent in the field of student behavior and student conduct. She adjudicated cases for all behavioral issues and policy violations at the highest levels of the college. Through this role, she was responsible for navigating Title IX compliance and implementation. It was here that Lisa gained many years' experience working with survivors, understanding trauma, and understanding the impact of dating and domestic violence, not only on individuals, but on the broader community as well. Lisa received her bachelor's degree from SUNY Oswego and her master's degree from Penn State University. Education is one of the most important and effective tools in breaking the cycle of abuse and stopping abuse before it starts. Willow's training and education program aims to break this cycle and address this issue of domestic violence across the entire community by directly serving as a resource for schools, community organizations, faith groups, medical and healthcare professionals, law enforcement, and civic groups. Lisa is a lifelong Rochesterian and loves a good garbage plate. I think we all do. and she and her spouse have 3 children and a passion for traveling the world, which they look forward to resuming in a post-COVID world. So now I will turn the presentation over to Lisa. Thank you.
Thank you, Laura, and thank you everybody for having me here today. I'm so happy to be here and to be with this group and joining on. My contact information I did put in the chat, so it's right here on this first slide. So if you're not savvy about screen grabbing, I'm also going to put really quickly the number for the National Domestic Violence Hotline. I know that this is a really diverse group of people who are joining us from all over the place. So I want to make sure that you have a great resource that's available anywhere in the US. So the National DV Hotline, that's in the chat group as well. So again, thank you so much for having me and thank you for that great introduction. So we're going to jump right into content and get started. So today we have bitten off a lot. So we have a lot of information to cover. We'll have plenty of time for questions. If you have questions, please feel free to use the chat and ask questions throughout. I'll do my best to kind of keep an eye on it and see what we've got in the chat as we go along. Laura, please feel free to monitor that too and jump in if there's questions that I've missed. Today we're really going to be talking about abuse and trauma. We're going to talk with a focus on how abuse affects older adults and a focus on what has been happening during the pandemic. We're going to talk about the basic intersection of substance use and abuse and domestic violence as well. It's a surface level there, so we're just going to kind of hit some of the basics. As we're talking today, please know that this can be really difficult information to listen to and to hear. So please take care of yourself during the discussion. After the discussion, I don't want people to walk away with feelings that will ruin the rest of their day or the rest of their week. So please do take care of yourself. And again, please don't wait for those questions. Please feel free to put them in the chat as we go. All right. So just a little bit about Willow. So I know people are from all over the place, but this is who we are. We have been in Rochester and Monroe County for over 40 years. For nearly 40 of those years, we were Alternatives for Battered Women, or ABW. So if you're here in Monroe County or in the area, you probably will remember ABW. We rebranded in 2016 and changed our name to Willow. There's 2 giant things that are wrong with ABW. The first thing is women, because we serve women, yep, a whole lot, and we also serve men and children. So that women piece was not inclusive of who we are and who we serve. The other term that we needed to get out of there was battered. Battered is an old term that we don't really use in the field anymore. And also it implies that the only way to be harmed through domestic violence is by physical violence. And we know, and we're going to talk about today, that the spectrum of violence is much broader than physical violence. And that painted us into a corner we were uncomfortable in. So we changed our name to Willow in 2016. We are the licensed residential and non-residential provider by the Office of Children and Family Services here in Monroe County. There are other DV providers here in the county that are licensed and they're wonderful partners. We're just the flagship for the county. If you are in New York State and you are looking for another DV provider in a different county, a great resource is the New York State Coalition Against Domestic Violence. You can Google that. They actually have a list of providers by county on their website, and we can share that in the chat at the end too. But that's a great resource if you're looking for something outside of Monroe County. Here at Willow, we are safe zone trained, which means we are welcoming of all genders, gender identity, gender expression, sexual orientation. We also have staff who speak Spanish fluently. In nearly all of our programs, we can usually find somebody who's available. And if not, we regularly use Language Line. We also regularly use ASL interpreters. We have 2 deaf staff members on staff who serve our deaf and hard of hearing community here in Monroe County. For those of you who don't know, we have the largest per capita population of deaf and hard of hearing people in the country here. So it's important that all of our services are inclusive of our deaf and hard of hearing population as well. We are doing a lot of things at Willow. So here's a broad spectrum. I'm not going to review everything, but this is what we are doing. What's important for anybody to know, and especially any provider here in Monroe County and surrounding counties, is those crisis interventions 24/7. We have the hotline that you can call, you can text the hotline. We have real-time chat on our website and through Facebook Messenger. All of those options are real humans when you make that call or put that chat in. It is a human on the other end. It's not an answering service. It is a counselor as soon as somebody picks up the phone or answers that text back. The 24/7 service is meant to really be a crisis intervention hotline. So for survivors calling who are in crisis, but what we also do is that we support the people who are supporting survivors. We regularly get phone calls from family and friends. We regularly get calls from service providers as well, asking questions about services, resources in the area. Can you just give us some tips? We're working with a patient or a client. Can you just help us walk through this? What we see a ton of time actually is providers who will call us and they'll say, hi, we're sitting here with a patient or a client and they want to talk to you. We want to all talk together. Can we put you on speakerphone? Absolutely. Boom. Put us on speakerphone and we can all have the conversation together. As long as your client or your patient is okay with that, we are absolutely happy to help facilitate that conversation in the moment when it's most important to that person. So please feel free to use those numbers. If you're local or if you're not local, we're not going to hang up on you. We're happy to help you. We do have obviously a lot of other programs. We have that emergency shelter. We do house adults and children. Typically, we're about half children at any point in time. We have a pet shelter, which is important because we know that about 60% of survivors will not leave a dangerous situation if they have to leave a pet behind they believe is in danger. That pet shelter is pretty unique to what we do. Only about 8% of domestic violence shelters have pet capabilities in the country. So this is a really important service. Our counseling center is available as well. You do not have to be living in shelter to use a counselor. The vast majority of our counseling clients are not in shelter with us. We have advocates who are right downtown at the Hall of Justice who help survivors navigate the order of protection system as well. We're not attorneys, but we do have access to legal aid attorneys who are right there with us and through some of our other programs as well. We also have mobile advocates who are able to be sort of on the road and meeting clients where they are. We're the first agency in the entire country that was able to secure orders of protection on the road through virtual, even pre-pandemic. We were doing virtual orders of protection for people who have significant barriers to accessing court and actually physically getting to the Hall of Justice. We were able to work on a process to facilitate them electronically. So that's a service that we offer to qualifying clients. We work in human trafficking. We do sex trafficking and labor trafficking. Like I mentioned, we do have also 2 deaf staff members who work with our deaf and hard of hearing population, and prevention education services. That's this, and everything that we do is free. Every service that we have is free, it's confidential. Clients don't have to be worried about insurance or charging or anything that we do. Okay, so we're going to start a little bit talking about trauma. So for those of you who are familiar with trauma, stick with me. It's a great refresher. So this is the definition that SAMHSA provides as trauma. What's important about remembering what trauma is that trauma can be a single event or it can be a series of events, so complex traumas. So single trauma is things like a car accident or witnessing one violent act. Those are one-time single simple traumas, simple in quotes, traumas. There's also complex trauma, and complex trauma happens to people over time. It can happen when traumas are layered on top of each other. The pandemic is actually a pretty good example of a complex trauma. So anybody who is living in a traumatic situation, so maybe in a domestic violence situation, now has the pandemic that's on top of that, which is a traumatic situation in and of itself. So it's when trauma gets layered on top of each other that we see complex trauma happening to people. So whether trauma is domestic violence related or whether it's related to something else, so, witnessing a violent event or, a car accident or maybe a major weather disaster with our friends in Texas, what we're seeing right now, the reaction to trauma for people is really the same. So this, you can look at anybody experiencing trauma and look at this definition and have it be applicable. Important things about the reaction to trauma is that trauma reactions are not a sign of emotional or psychological weakness or a mental illness. They are a normal response to an abnormal event. We do not expect things like terrorist attacks to happen, and when they do, we respond in the way that biologically we are programmed to respond. That is normal in the face of an abnormal event. Individual personality characteristics also count little for overwhelming events as well. And we see this in even our most highly trained people. So when we look at like police or military and we see people freeze on the battlefield, that's what trauma looks like. I can be trained, you can train me all day long, but as soon as I get out there and I feel that trauma situation happening, my biology kicks in and I might not react in the way that I was trained. So even our most highly trained people experience trauma in ways that we don't anticipate them to be experiencing trauma. So the idea of trauma-informed care, those are the principles of trauma-informed care. These are, if you're not familiar with trauma-informed care, Google it. It's a fascinating and wonderful field of study. There's tons of reading and tons of videos out there on YouTube to watch to understand a little bit more about trauma-informed care. But trauma-informed care is establishing sort of a baseline of safety and trust and support and empowerment. Choice is a huge part of the trauma-informed care system and trauma-informed care approach. And recently, cultural and historical and gender issues were actually added to the idea of trauma-informed care as well. So the basic idea here of trauma-informed care is the idea of asking what has happened to you, not what is wrong with you. So especially in a medical model, when we approach people, we look at like, what is the problem? Let's look at that medical thing and let's get in there and fix that. And the idea of trauma-informed is to zoom that out and say, okay, that is why you came in today, but let's zoom it out and say, what else has happened to you? What else has gotten you here today? What is going on with you? And that often yields more information than just focusing sometimes on that laser piece that somebody has come in asking for help for. So the idea of what has happened to you. So thinking about trauma across the lifespan. So I know that this series of education is really geared towards older adults. So when we look at things like adverse childhood experiences, you think Lisa Nolan. Why are we talking about childhood if we're talking about older adults? Because the beautiful thing about older adults is they all have one thing in common, and that is that they were all children. So we have to look back at childhood to inform us of what is happening in adulthood. So if you're unfamiliar with adverse childhood experiences, the CDC has lots of excellent resources on their website, great videos, great graphics. You can check that out. Adverse childhood experiences are potentially traumatic events that occur in childhood, so from 0 to 17 years old. One of the most common ACEs in Monroe County, we know from the Youth Risk Behavior Survey, is domestic violence. So when we're seeing clients here in Monroe County, when we're seeing patients and people that we work with, it is really important to keep their past and their childhood in perspective, because oftentimes it does inform what has happened to them as an adult or where they might be as an adult. So we see three categories of ACEs here. It's abuse, neglect, and then household dysfunction. Most children who experience ACEs in Monroe County have sort of a smattering of this. Many of them have 4 or more ACEs, which is a critical number for putting people on a path to success and health long-term and poorer health long-term. So ACEs can impact risk for issues later in life. We see ACEs having a significant impact on cognitive health and development, that people have dementia and sleep issues later in life. It impacts our physical health. We can connect heart disease, we can connect chronic fatigue, we can connect lung disease, diabetes directly back to those ACEs that were experienced in childhood from 0 to 17. It has a significant impact on our mental health, depression, anxiety, suicidal ideation, our mood, even as adults. So if I'm 60 years old and I experience this as a child, it can still impact how I behave as a 60-year-old. And certainly, it can be a risk factor for substance use and abuse and overall risky behavior as well. We know that ACEs are not a silver bullet either. So that's a great disclaimer here as well, is that if you are experiencing ACEs and even a high number of ACEs as a child, it doesn't mean that you are doomed, that you have some kind of fate as an older adult. It just puts you set up for risk factors. So we know it doesn't always correlate that way, but the risk is definitely there. So when we're meeting with older adults, when we're thinking about what's happening with them, this is a great place to start, is rewinding back to childhood and asking some questions. We also know that trauma impacts people differently over the lifespan as well, and can evolve or resurface or just show up in general as an adult. It is not uncommon to see older adults have symptoms or issues that emerge either after a long period of time being symptom free, or their whole life being symptom free, and then all of a sudden pop up as an older adult that something is happening. So we do sometimes see symptoms happen for the first time in adulthood. Symptoms can also be more extreme than previously experienced. So even when we see young people going through traumatic experiences and maybe they kind of work through them and are empowered to make some different decisions and are healthy, we can see sometimes that in adulthood, the symptoms come back and then they're more extreme. So we see more extreme fatigue, more extreme depression, more extreme risky behavior as an adult based on those childhood experiences. And certainly symptoms can present differently. You know, we think about the mentality between a 20-year-old and a 6-year-old, it's pretty big difference there. So we know that, you know, if this is the way that even a 25-year-old was working through a traumatic situation, that a 60, 65-year-old person is going to work through a situation differently. It's only natural that we would do that. It's not the same person, it's not the same maturity, it works differently. So symptoms can present differently in a younger person than they can in an older person. Triggers. So people are triggered by all kinds of different things as adults. Some of the things that are on here, one of the things that I did want to mention too is that you are a trigger as a provider. As much as you don't want to be, as much as you are creating a safe space, and even if you are trauma informed, you need to know that you are a trigger by nature of the system that you work in, the processes that you have to follow, and the power element that there is to this. Especially as healthcare providers, we have a lot of power over people. We have power over their records, we have power over prescriptions, we have power over access to other resources, and that can be a huge trigger for people who have experienced trauma, especially trauma in domestic violence. Because as we'll talk about in a couple of minutes, domestic violence is all about power and control, and helping survivors work through that is about restoring the power and control back to them. So when they get in systems and they feel like they don't have control, this can trigger all of that trauma and that trauma response back to a provider and make them look uncooperative and be a pain sometimes. All right, just checking the chat really quick. Okay, great. All right. So why this work matters, trauma and domestic violence, this is our national statistic for people who experience domestic violence. So we know that 1 in 3 women and 1 in 4 men will experience domestic violence in their lifetime in the United States. That is a huge, giant number. It is really hard to conceptualize that when we think about it. Here in New York State, our definition of who domestic violence can occur between is here below. It's intimate partners, so those romantic relationships, current, previous, married, divorce. We're lucky that we include LGBTQ+ people here. That's not included in all states and communities, so we're lucky here in New York State. Our definition here also notes that you can be related by blood, so parents abusing children, children abusing parents, siblings abusing each other, that's a thing that happens, and people who are related through marriage, so in-laws, step-parents, and stepchildren in that abuse cycle as well. It's important to remember that domestic violence, yes, occurs between intimate partners, but it also includes between family members too. So it really broadens the scope in that 1 in 3 and 1 in 4 of who is a survivor of domestic violence. So really, truly, we all know somebody. If you have been disclosed to, or whether you've not, you definitely know somebody. You might not just know because they might not disclose to you. So the scope of domestic violence is that there also is no face to domestic violence. Anybody can be a survivor of domestic violence. Typically, we have a stereotype of who the survivor is. It's almost always a woman for everybody. Men are absolutely survivors of domestic violence. We see many, many of them through our programs here at Willow. And they can be from anywhere, from any background, from any race, from any sexual orientation, ability, education level, zip code. Survivors are everybody everywhere. Now, the flip side of that is that abusers can be anybody too. So abusers abusers are beautiful, gorgeous people that we all want to date or have in our families. They look just like everybody else. So actually, a really great tip, if you're ever working with a survivor or a friend ever discloses to you, is that if somebody discloses to you and you say, no way, that couldn't be, not that person, not Lisa Nolan, she's so great, she couldn't be abusive, that doesn't seem right to me. That is your first red flag that absolutely that person can be abusive, because abusers are beautiful and gorgeous, and they use power and control tactics to manipulate everybody else besides the person that they're horrible to. So that's a great first red flag if you're ever thinking about like, no, couldn't be that person. Now there is a but here, and it's a pretty big but. So yes, abusers can be anybody. Yes, survivors can be anybody, but we know that there are groups and populations who experience this stuff at higher rates. We know the LGBTQ community has higher rates of intimate partner violence. We know the deaf and hard of hearing community have higher rates of violence. We know that specifically women of color experience higher rates of violence. And not only that, they have a higher risk of death related to intimate partner violence as well. So while we have to smash that stereotype in our head of who this could be, we also need to know that there are populations and risk factors where this is a much bigger issue. So when they disclose to us or talk about things that are concerning, we need to really lean in and pay attention, because the risk factors are much, much greater. So domestic violence is that pattern of behavior. It's aimed at gaining and maintaining power and control over a partner or over an individual if it's a family member. The important pieces of this are pattern. This is a pattern of behavior. Domestic violence is not an accident. It's not a one-time thing. It's not I saw red and then I just snapped and something happened. This is a pattern of behavior over time, and it's pretty clear when we start rewinding back and can look at it. It's also about power and control. So this is a choice of behavior. This is not an anger management problem. This is a question that we get a lot. Well, aren't people who are abusive, don't they just have anger management problems? The answer to that is no. Anger management is a diagnosable mental health issue. And people who have anger management issues are angry at everybody. Their anger doesn't discriminate at all, ever. They're angry at their boss and their family and their friends and the guy on the street. Everybody suffers the wrath of that anger. But when we think about abusers and that beautiful, gorgeous Lisa Nolan, and she can never do that, it's because they're not angry at everybody. They take their anger out and they choose to abuse that one person or that select few people. And that makes that behavior a choice and not a mental illness. It's also, like I said a couple minutes ago, it's purposeful and strategic. It is not an accident. This is not a one-time thing. We don't call people names long-term because it's an accident. This is something that continues to happen, and it is purposeful. So we're talking about substance use and abuse as well as part of this group. It is not, substance use and abuse does not cause domestic violence. That's another important myth to sort of smash here today, is that yes, it makes it worse. It can make it more frequent. It can make it more violent depending on the use and abuse pattern, but it is not the cause of domestic violence. It is a risk factor. So again, people who use substances, people are more at risk of being a survivor. People who use substances may be more at risk of becoming an abuser, but it doesn't cause the abuse. So the same thing that makes people go out on a Friday night in normal times, non-COVID, and drink too much and dance on a table is the same thing that makes people go on a Friday night, drink too much, and go home and hurt their person. It is a choice that's within us that's inhibited by using the substance. It's not directly correlated in that causation role. If it was, then we would just get rid of drugs and alcohol and we would have no more domestic violence, but that's not the case. So no domestic violence presentation would be complete without a power and control wheel. This is the power and control wheel for older adults. It's adapted from the Duluth model. Again, you can Google Duluth model and you'll come up with like a dozen wheels. There's actually a disaster wheel as well. So if you're interested and curious about what power and control looks like specifically in the pandemic, that's also available, is that there's a scenario for disaster and situations just like this. So when we look at something like a power and control wheel, we look at the information that's on here. And now in the center is that power and control, because that is at the heart of the behavior of an abuser. It is all about power and control. Now, when we ask abusers, like, why are you doing this? What is going on here? They're not going to say power and control, right? But they're going to give us reasons and behaviors that can all point back to and lead back to that power and control piece. The tactics that they use are on the inside spokes of this wheel. So ridiculing, that emotional and that verbal abuse of a survivor. It's manipulating the family, misleading people. It is about making excuses for behavior, minimizing behavior, denying behavior, blaming it on a survivor. So that sometimes sounds like, somebody says some really horrible things to you. And I say, well, that was terrible. You can't say that to me. That really hurts my feelings. And an abuser might say something like, oh, Lisa, you're so sensitive. You take everything too seriously. I was just kidding. Don't even pay attention to Lisa. She's just an emotional wreck. I've totally minimized my own behavior and I've blamed it on the survivor, that it's your fault for being emotional and not my fault for harming you. That's how crafty manipulation can sound. You will notice on a power and control wheel that the physical and sexual violence is on the outside. Now, typically in a violent relationship, whether it is an intimate partner relationship or whether we're talking about a familial relationship in the home, that physical and sexual violence typically happens last in the cycle of violence when we see that happening. We typically see a lot of this other behavior, the financial abuse and exploitation, the threats, the intimidation, the verbal and the psychological abuse and the manipulation, long before we see any kind of physical or sexual violence. Now, again, that's not a silver bullet. That's not always the case, but that's typical pattern of behavior. So again, when we're thinking about the clients and the patients who are in front of us and how they might be presenting, we're often as healthcare providers looking for those physical signs of abuse. But what we really need to be asking about is what else is going on? What's happening with the relationships in your life? Who is supporting you? Do you have the resources that you need? And specifically for older adults, one of the things that we see is healthcare being a real tactic for power and control. Somebody taking control of the healthcare, somebody holding on to that and getting limited access. It can be somebody abusing prescriptions and literally taking the prescriptions and I will tell you when you can take them, or hiding them. So healthcare is actually a place where we see that power and control dynamic very, very strong for survivors. I see chat activity, so I'm just gonna click on that. I can try. Go. Nope, it's not letting me open it. Okay. We'll continue on then. So this is actually a great tool. I recommend to lots of service providers that whether it is this wheel for older adults or if it's just the general power and control wheel, this is actually a really great thing to print out, stick it on your office wall, stick it in your pocket, because when you have that feeling of something is going on here and I can't quite put my finger on it, this is actually a great resource to check, look at it. You might find something on there that hits that bullet for you that you're like, oh my gosh, this is what it is. I knew it wasn't right. I just couldn't quite put it into words. So this can be a really great resource to kind of keep in your pocket. I wanted to just show this slide really quickly as it references to older adults, because we hear this from older adults through our services all the time. Oh, well, it's not that big of a deal. It's, it's a little bit, or, I'm minimizing my own feelings in this situation. And this is definitely a generational issue too, that, it's not that big of a deal. But there is no such thing as being a little bit of abused. I call this the Law and Order SVU syndrome, is that we can watch that show and think to ourselves, oh my gosh, that's really bad. Ugh, what I'm experiencing is not that bad, so I guess it's not violence. Untrue. Any type of abuse at any intensity or frequency is not okay. And older adults often don't want to burden people with those things that they feel are insignificant or just a little bit. So a pattern of abusive relationships is always going to kind of look like this. So there's this period of calm and honeymoon, there's that tension that builds and rises, and then boom, there's an explosive incident that happens. So again, explosive incident can be anything. It can be the verbal abuse. It can be the minimizing, denying behavior. It can be, I took all the money out of the bank account just to show you I could do it. It could be making a threat, whether or not I carry that threat out. But this is always what the cycle is going to look like. So as we see patients and clients coming in and out of our services, they may be anywhere in this pattern of behavior. This can happen 10 times in an hour. It can happen 10 times a day, a week, a month, a year. It can happen once every 10 years. But this really is how the cycle is always going to look in an abusive relationship. The important thing to know that is frustrating for us as providers is that it's not always bad. And there can be really long periods of happiness, which are frustrating for us because we can see that there is something that is likely going to happen and that is going to come because we've seen the pattern and we understand how it works. And the survivor isn't there yet. They don't see it or they're not ready to accept it. And so when they're in that period of common honeymoon, they're hanging on to that. And that can be really hard when you're the support person. Over time, the cycle looks a little bit different. So that honeymoon phase gets a little bit smaller and that calm phase gets a little bit smaller if we're talking about family dynamics. And those explosive incidents get bigger and bigger and bigger until a lot of times the honeymoon in that calm phase is completely gone. It doesn't even exist anymore. Someone is living in a state of fear and a state of trauma and a state of constant vigilance because they know that something is coming. All right. So when we think about older adults and we think about how people are presenting, oh, substance abuse is on there, how people are presenting to you, we often are looking at them in the one lens that they're coming to see us with. So this is that top of the iceberg. So when people are coming through our services at Willow, they're coming through as a survivor. That is our first thought of who they are and why they're here with us. It might be an older adult for you. It might be just a patient. It might be someone who uses and abuses substances. So that's the lens that they're coming with top of the iceberg. But what we have to remember in that theory of trauma-informed care and the practice of trauma-informed care is that we do not live single issue lives. So much more is under that iceberg. So when we think about, we recycle back to the beginning of the presentation, we were talking about trauma and what kinds of trauma there is complex trauma. And most people who are in front of us, especially if we're talking about substance use and abuse, especially if we're talking about older adults, have multiple layers of trauma. So if a survivor is coming to us, they're coming to us through our door as a survivor, but they might also be somebody who has a really high education level. Maybe they have a PhD. Maybe they have a faith background that dictates some of the rules and thoughts and theories in their life. Maybe they live in a rural community. Maybe they are a person of color. Those are multiple traumas that are stacked on top. So when we use a trauma-informed care approach, we have to zoom out and consider all of those things that somebody is going through to help them get the best service and the best resources that they need at that time. We cannot just look at somebody in the scope of that one thing that they have come to us for because it doesn't work. But what we also know is that each piece of this iceberg and each piece of our identities makes it so much harder for survivors to gain access to services and support and for them to be believed. When we start layering the traumas on and we say, I'm going through this and this and this and this, the likelihood of other people believing them and saying, I believe you, gets lower and lower and lower and lower. How could that be happening to somebody? So much stuff. It definitely could be, and it's happening to lots of people. So we have to know that the more complex trauma that we have, the greater the barriers are to getting access to services and support. So a little bit about the intersection of domestic violence and substance use and abuse is that substance use and abuse is a tactic for power and control. So domestic violence and violent behavior is about power and control over a person. When we see substance use and abuse as a tactic for power and control, we see it happen in a lot of different ways. So we see abusers who help, I'm going to put help in quotes there, someone become addicted and then keep them addicted. So prior to being at Willow, I worked with college students all the time. And actually, this was something that was on the rise as I left that role and transitioned into this one, was that we were seeing a lot of abusive young people, and they were introducing somebody to drugs or alcohol and then continuing to provide them with that, so that that person was stuck in an addictive state and that person was their supplier. So fully controlling them, because that's who they had to go to for their next thing. So they're controlling the access. Sometimes it will induce withdrawal, right? So if you get somebody addicted to something and then you say, well, I'm not going to give it to you anymore, and it's a legal substance, and where else are you going to go to get it, and you're not safe, then I'm going through withdrawal symptoms. And then I just dangle that carrot in front of you. And that is how I stay connected in this relationship. And that is how an abuser maintains power and control over me. It also looks like isolating from recovery. So I might, recognize that I need help, but my abuser is limiting my access to that. You will not go into recovery. I'm going to keep you addicted here, and I will not allow you to have access to the resources that you need to get clean or recover, or even start down that path. Substances are used for threat of harm, especially when we think about things that are illegal, right? If you are using drugs that are illegal, we'll call the police on you. You want me to call the police on you? Because I will, because I know that you have it in your car, on your person, or you're going to buy it from this person, and I'll call the police and tell them that that's where you're going to be, and this is what is happening. So again, a tactic of power and control there. When we're looking at parents of children, it's a threat to call CPS. If you're addicted to something, I will call CPS on you. We have advocates who work in CPS, and anecdotally, they tell us that about 50% of the calls of clients that they meet with are revenge calls and spike calls for exactly some of these reasons. We also know that there's a threat of overdose that happens as well. Do you know what's in that substance? Because I know what's in that substance, and you could be fine doing it, or you could die because I might just give you so much that you will overdose. So there's always a threat of harm in that way too. We know that substance use is a justification at an excuse for abusive behavior as well, both on the part of the abuser. So I was drinking, I was using a substance, I'm sorry, it wasn't my fault, I snapped, I wasn't sober, I didn't know what I was doing. And we also see the same justification and excuse making from survivors too. So people who are in relationships that they don't want to leave or not ready to leave or whatever, and they're saying, well, they just drank too much, or they just took too much stuff, and it's only happened a couple times and it won't happen again, and that they will use the substance use for justification for an abuser's behavior as well. It's not, by the way. But we also see substance use as a coping mechanism. So survivors use substance use and abuse for a coping mechanism too. So we know, again, recycling back a little bit, that this is a risk factor for becoming a survivor. So if I'm already using substances, that's really easy for an abuser to see me as a vulnerable person in a vulnerable population, to say, I'm going to exploit you, and this is how I'm going to gain power and control. I'm going to use a substance to get in on that. And when we're talking about older adults, we're talking about prescription medicine, we're talking about opioids. I see that you're using that, I'm going to get in there and exploit it. And we see survivors using it to self-medicate. So now I'm in this situation, no matter how I got here, no matter what happens to me, now I'm in it and I can't get out of it and I'm stuck here. So now I'm using substances to self-medicate from the abuse. I'm using it to escape, because while I'm using, I don't hear the abuse that happens as much, or I can tune it out, or I can push it back more or farther or deeper. So I'm using to kind of escape and cope from that as well. We also see survivors use substances to prevent harm. So I might be supplying the abuser with the substances so that they will get really drunk, and then they'll pass out, and then they won't hurt me. So we do see that kind of behavior that happens as well. And we have to be really careful not to judge that when we see that from survivors, because that's safety planning for them. That's, I know that if this happens, if I do this, I will be safer in the long term. So legal or not legal, we have to really take a step back and not judge that when we hear that, and think about it as a safety mechanism, and then think about solutions, and maybe some different solutions. But we have to be really careful not to judge that when we hear that from a survivor. So for women too, I just wanted to highlight, so again, this kind of behavior happens to all people, men, women, non-gendered people. But for women, the intersection is really significant between DV and substance abuse. We know there are some stats here that women in treatment most of them are survivors of some kind of intimate partner violence or domestic violence in their lives. And we know that the stigma can be greater for women too, that especially if you are a parent, right? So I know we're talking about older adults today. So if you have children who maybe are older, or maybe if you have children who are younger, there's a significant stigma to coming forward and saying, I have a substance use and abuse issue, and I'm a parent, and I'm experiencing domestic violence. Again, we're layering that trauma on, and the stigmas of coming forward can be much greater for women sometimes. So there's a lot of barriers in this intersection as well. So resources we see are often very one-dimensional. So there are substance abuse, there's domestic violence, there is mental health. They are very specific, individualized interventions that don't often collaborate and work together well or at all. We know that a lot of resources can be gender specific and also not family focused. So sometimes when we see services offered, so again, our services at Willow are open to anyone, regardless of who you are, where you're from, what your background is. Men, women, children, non-gendered people are all welcome through our doors. But we know that there are other domestic violence providers out there who are gender-based. And that's a barrier. So when we think about that, we can think about substance use and abuse issues too, that there are programs that are out there that are gendered for men or women. We know that many services are not family focused either. So again, if I have small children or even older children, my children need care, are the services available to me inclusive of having care? Do they have care? Will they make accommodations? What if I'm a grandparent and I'm raising my grandchildren? That's a barrier that we know exists and prevents people from accessing services. We, by the way, at Willow have free childcare. As long as we have advance notice, we're able to help people with that so that that doesn't have to be a barrier. And the stigma and guilt and shame are humongous here, and even more so as the issues are layered. So we think about how much stigma there is in substance use and abuse. Last series last month, I sat in on that one. It was a whole hour presentation about stigmas of substance use and abuse. So if we think about that, and then we put all the stigmas in front of us about being a domestic violence survivor and an older adult domestic violence survivor coming forward, and we put those together, the barriers are humongous for people to come forward and access services. So we really do have to think about how the services we are offering are inclusive or not inclusive, and what is our messaging about coming to us and accessing those services. So just a little illustration here. So when we think about sort of those barriers in those groups, this is the small scope of the iceberg. So if we just take 3 things out of there, right? We're talking about older adults today, we're talking about domestic violence survivors, we're talking about substance use and abuse, that those services that are available are really tiny on the inside of the concentric circles here that are available to people just to begin with. So we have to look at who is in front of us and look at what may have happened sort of in these intersecting services as well. So what has somebody already been through? What are the barriers that they have already had to overcome to even get to you? And how are they feeling based on that? So again, taking that trauma-informed approach. So when we see a survivor in front of us and somebody who's using substances, or maybe somebody who's in recovery and they're an older adult and they are frustrated and they're not cooperative and they don't want to listen to you or they don't want to talk to you, and you're thinking, why did you even come to me? Well, let's look at this list of questions. What has happened to them that has put them in front of you? What barriers have they already had to overcome? Who has already told them no? Who has already not believed them and put them in their place? And let's start there. What has happened to you, and how can we best serve you in this very specific set of services that you do need? So it's taking that backward rewind and saying, what has happened to you? And sometimes we literally have to rewind to childhood to say, Lisa, I get that you're here today because you're using a substance and you need to get your diabetes under control, and you have not a great support network at home, and you're in this dangerous relationship. So we really have to think about what happened in childhood too, to say, hey, I get that you're here for these things today. Can we just talk about, like, how has life been? Tell me where you've been. Tell me how you got here. Tell me what's going on with you. And that can really help inform where somebody is today. Because as we already talked about today, this could be trauma that has gone unaddressed for years and years and years. And it is showing up right now because something has triggered it. So let's figure out what the trigger is, and let's help you bring it down just a little bit. So another piece of advice too is, if you are a healthcare provider, or actually if you have young people in school, your kids can tell you this, is another great way to think about trauma is the flipped lid concept. So, our brain, when our brain is functioning in a non-trauma mode, our doing brain is kind of like closed up and we're just walking around functioning. When a trauma happens, our lid flips, and what's exposed in quotes here, is our amygdala, which is our caveman brain, right? This is fight, flight, freeze. This is non-scientific dive, people, also. So this is our caveman brain right here, right? So when we are experiencing trauma, this is happening, our lid gets flipped. So our rational, emotional thinking brain is out of commission, and we are just trying to survive. So when you see somebody in front of you and they are just trying to survive, the solution is not to close the lid completely. We're not trying to do that here at Willow, because we know that that's not realistic. What we're trying to do is just get them to come down a little bit and a little bit and a little bit, and maybe halfway, or maybe just that little bit. So thinking about that scope of the iceberg, and how do we bring you from a here to a here, knowing that what you're experiencing is traumatic. So what do we do? How do we actually do this? Ask people. I know this is really hard. I do training for medical residents all the time. They're like, Elisa, I don't know how to ask the question. Just ask the question. It's okay to ask people about their relationships. It really and truly is. And many people really want you to ask about their relationships. It's okay to ask people about the safety and the happiness in their relationships. So, medical providers are trained to say, are you safe at home? It's not a great question, because is there a bear in my house? No. Is my house going to fall down? No. So am I safe at home? Yeah, I guess so. Let's talk about what is going on at home. How are your relationships at home? Who do you live with? Do you feel safe? Do you feel like you have all the resources and support you need in your home environment? Let's start there. We also know intergenerationally, especially as we're talking about older adults, that there's this idea of it's none of your business. Whatever happens behind a closed door stays behind that closed door, and you can't ask about that stuff. You can ask about that stuff. If you went to the wedding, you ate $100 plate of food, you can absolutely ask then, how's that relationship going? It's totally okay. It is definitely your business. And then believe them. So if you take nothing else away from today, I do want you to remember this. Please believe survivors. As we will believe people who say, I have a substance use abuse problem and I need help, we're going to say, great, I believe you, and let's get you that help. When somebody says, I am surviving something bad is happening to me, please believe them. Even if in your back brain you don't, I want you to just say, I believe you, and then no more words. We hear from survivors all the time through our programs, and specifically our court program, that just somebody sitting with them and saying, I believe you. I don't need you to tell me all the details. I don't need you to explain anything. I believe you. What can we do from here? That makes all the difference in the world for so many people. You might be the first person that believed them. They might have told 100 people, and you're the first person that believes them. That is incredibly important. Just believing and then listening. We try not to judge people, and we don't give people advice. Even when they say, can't you just tell me what to do? No, we cannot tell you what to do, because I don't live in your shoes. I don't live in your situation. Just like we're not going to tell people what to do when they're in recovery, we can say, here are all your options. Here's everything that's available to you, and here's how I can assist you with this. We're not going to say you must do this and this and this. When you start hearing the words out of your mouth like, I think you should, or you could, or I would, or I wouldn't, that's when we know we've made it about ourselves and not about the person in front of us. So turning that question around and asking, well, what do you think that you should do? What are options that you know that are available to you? And then how can I help you come up with some other different options? We don't frighten people into making decisions. We don't bully them. We don't do anything on their behalf without their permission. So we have a lot of wonderfully well-intentioned medical providers who will see somebody who's in danger and they'll get really, really scared. And they'll say, oh my gosh, you need to get out of there and you need shelter. And they'll do whatever they can. And they get on the phone and they call every single place and they finally get somebody to bed. And then the survivor will call us and they'll say, I don't want to be there. And we say, okay, well, what do you want to do? And the service provider has really seen the situation and they believe that that's the right thing to do. But if the survivor doesn't believe in that and that's not what they want to do, it's going to be completely ineffective anyway. It's not terribly different from substance use and abuse. If somebody's not ready to be in treatment, to be in recovery, they're not going to be successful and they're not going to do it. It's the same with domestic violence. If somebody's not there and they're not ready, if ever, then we can't push them to do it because they won't do it. Everybody has to make their own decisions in their own time about a dangerous relationship. It's not on my time. It's not on your time. It is on their time. Just like when we look at that treatment and recovery models. It's like I talk about this all the time. It's really like establishing a new habit. So if you have ever tried to be on a diet or exercise or bullet journal or read before you go to bed or something, you will likely know for yourself that it was really hard and you probably weren't successful and you probably weren't successful on the first try. And if you were, high five from afar because you're nailing it. But most people are not successful on the first try. And it's the same with domestic violence relationships. Even if I want to leave, it takes a long time. And I'm not just talking about like not eating cheeseburgers, because what we're talking about here is we're talking about stopping access to a human. If we're thinking about older adults, and we're thinking about who is abusive to older adults, maybe it's a partner or spouse, maybe we've been married for 40 years. Am I really going to just flick that light switch off and have them cut out of my life? That doesn't sound realistic to me. What if it's an older adult and their children are abusing them? Are you going to really just cut your children out of your life? That doesn't sound realistic to me either. And even if it is realistic for that survivor, it is certainly not going to happen cold turkey. So we see people over long periods of time trying to escape if they ever choose to do that. It's in their time, it's not on our time. So we want to make sure that we're giving support, resources, options, and choices. Remember, domestic violence relationships are about power and control. When we meet with survivors, we are trying to give them their control back. Even if it is as much as like, what color toothbrush do you want? I don't get to make those decisions ever in my life, so I'll take the pink one. That sounds great. Giving control back whenever possible, even if you have to set parameters around it, right? So we have to follow policies, we have to follow procedures. So we can say, here are the policies and procedures that we have to follow. But within this box, what are the choices you want to make? Here are the options that are available to you. What do you think? Give the survivor the choice. Give your client the choice that helps them buy into whatever it is they're choosing anyway, and will likely make sure that they're more successful. We connect people with resources all the time. If we're not the right stop, we're trying to find people who are the right stop. And follow up. So for healthcare providers, this is really important. The follow up is your underrated tool, underrated, underused tool. Call your patients back and say, hey, Lisa, I just wanted to follow up with you and just checking on you. How are you doing? How are things going? Especially if you are concerned about somebody, if you are worried about their safety, follow up, call, check in on them. If you're meeting with them in a confidential setting to provide them services, and you can say, hey, listen, I do want to follow up with you. Can I call you? When I call you, here's what I'm going to ask. And if it's not safe, here's how we're going to do it. And if it is safe, here's how we're going to do it. It's a great way to be able to follow up and know that somebody is safe and to be able to get them resources. If you're worried about following up with somebody, make up a reason. It's okay. Say, oh, hey, Lisa, you know what? The electronic medical records went down when I was doing your stuff. I just have to ask you 2 quick questions. Again, I'm really sorry to bother you. Can I ask you these questions? Make up the questions. That doesn't matter. You can just put whatever you want down there. But then you can say, oh, and while I have you, can I ask you just a question about this? Or I thought I heard you tell me something and I just wanted to follow up. That's a great entryway. You don't need, a real hard tack reason to give a call and give a follow-up, especially if you're trying to gauge somebody's safety. Get creative. It works. Don't confront an abuser. If you have the ability to not do it, please don't do it. When we confront abusers, what happens is that abusers become angry about that. And they don't really like their behavior called on to the mat. So, and when they get angry, as we know, their anger is a choice, and they choose who to direct it to, and they direct it to their survivor. So when we confront abusers, I like to call this the knock it off idea, because I feel like if I could just get to that person and tell them to knock it off, then they'll stop. They're not going to stop. And it makes it worse for the person that they're abusive towards when we tell them to knock it off, because then they're angry at us, but they take it out on somebody else. So if you don't have to confront an abuser, please don't do that. If you do, take the same trauma-informed approach as you would with the survivor. Ask them how they're doing. Ask them what's going on with them. Ask them if they need help and support. Point out that you notice that maybe they don't look so happy, or tell me more about this relationship. Tell me how you feel about your partner. And communicate concern for them. That will help establish a better relationship in a way that will get you more information about what is going on, but won't hopefully cause more harm for a survivor. And certainly set boundaries for yourself. It is not your job to save people. Not your job to save people. It's not my job to save people here at Willow, and none of our staff save people. People save themselves. Just like as healthcare providers, you can give people their prescription and their medical stuff. It's their job to follow it and do what they can to keep themselves healthy. You don't get to follow them around to take their medication, to tell them what to eat, to exercise. We do the same thing here at Willow's. We can't follow survivors around and put them in a bubble. It feels worse because it's violent behavior and it's scary. So when we feel like if they just, or if I just, it feels a little different than just take your prescriptions, just stop eating cheeseburgers, right? This feels a little bit more emotional, but you have to take yourself out of that situation and don't adopt the mindset of trying to save people. Once you go down that road, you're in way too far and you are not actually helping the client at that point. This work is hard. This work is really hard. We do this every day. We are the domestic violence experts here, and we struggle. It is a struggle. We have all kinds of resources and support networks that we use both internally and externally here at Willow. And if we're doing that, you should be doing that too. Take care of yourself and your colleagues. Know that you are going to get disclosures, and disclosures are a good thing. Every patient and client that you are in front of, you should just assume that they're going to disclose to you, because 1 and 3 and 1 and 4, that's most of your day, right? So just assume that it's going to happen. It's actually going to help you be mentally more prepared when you just think that it's going to be everybody. So assume that it's going to happen, and know that it's a good thing. It means that people trust you when they tell you, and that's a good thing. Know that you are going to be affected by the disclosures. You absolutely are. People are going to tell you things that are going to impact you. What are your triggers? Can you avoid the triggers? If you can't avoid your own triggers, how do you process the triggers, and what do you do? Who are your support and your resources? Set boundaries for yourself. Sometimes we have to set boundaries for ourselves with a specific client. Sometimes we have to set boundaries for ourselves with specific triggers and information, but recognize what those are and set those clear boundaries. That's self-care, and that's really important. We talked about it's not about you, it's about the client. Use the resources available to you and give each other space and understanding. When your colleagues are crispy and crunchy like bacon, we want to turn them off too, right? Because we're annoyed at them. We want to take that trauma-informed approach with our colleagues too and say, hey, what's going on? What has happened to you? Why are you behaving this way today? Is it something that happened? Can we talk about that? The trauma-informed approach works with pretty much everybody that you know. So feel free to have that what has happened to you rather than what in the world is wrong with you mindset with everybody. Okay, last thing. If you are surviving a dangerous relationship today, if I'm talking about you on this call, I want you to know that everybody is worthy of a healthy relationship. Every single person. Doesn't matter who you are, where you're from, what your story is, you are good enough just the way you are, and you're worthy of a healthy relationship. Whatever is happening to you or your loved one is not your fault or their fault. No one deserves to be treated this way. You are not alone. You don't have to be alone. I believe you. We believe you. There's a community that stands behind you. If you need help and support and resources, Willow is here 24 hours a day. Please feel free to call us, text us, message us. This is what we're here for. We're here to support you. And as a provider too, if you need to call us and say, hey, this crazy thing just happened, can I talk about it? Yes, you can. Please call us. That's why we're here. Okay, I'm going to stop sharing. I see the chat is starting to blow up.
That is okay. There's no questions in the chat yet. I think just a lot of thank yous, and that was awesome. So thank you so much, because that was awesome. I do have a couple questions for you that are not in a Q&A feature.
Great.
So I know you mentioned the question, what has happened to you? But then sometimes people shut down. So what are some questions? Because you said, you know, we don't want it to go all the way down. But what are some questions to start the conversation while not shutting the person down? Because some people can't start with the what has happened to you, but like that's too far.
Absolutely. Be patient. So this requires a lot of patience, because if somebody's not ready to disclose to you, they're not going to disclose to you until they trust you. So being patient, especially for healthcare providers, 2 tips for you. Number 1, make asking about relationships part of your routine. Tell people that you're going to do it. Say, hey, listen, Laura, today in your appointment, I'm going to ask you about some relationships at home, you know, romantic relationships. And the reason that I'm asking you about this is because it's really important to your health, your physical health and your mental health. And here are some reasons why. So I'm going to ask about that today. And every single time you come in, I'm going to ask you about that again. So whether that's 2 days from now or 2 weeks from now, I'm going to keep asking that question about relationships because it's really important. And that primes your clients and your patients to know this is part of the routine. So maybe I'm going to start thinking about how things are going. The other piece is to really qualify the questions. So especially when it's awkward and you're like, I don't even know how to ask this question. Like something is happening. I can see that it's bad. I don't even know how to ask the question. Own the moment. Say, hey, Laura, I literally don't know how to ask this question. It's very awkward for me to ask, but I need to ask you this because it's really important to your health. And then ask your question. Owning that awkward moment actually makes it less awkward, believe it or not. And it also tells somebody why you're asking. Qualifying that question to say, the reason I'm asking you is because of this. I'm much more likely to respond to you and give you an honest answer when I know why you're asking and what you're going to do with the information. Because the fear always too then is, where does it go? Who else are you going to tell? Is my abuser going to find out? Are you going to put this in my medical record? What happens with this? Because I don't want it any there. Are you going to call CPS on me? I don't know. So I'm not even going to go there. So
the other piece of that is the older adults come in with a caregiver. So
yeah.
How do you get them away from the caregiver and talk to them alone without offending the caregiver or tipping the caregiver off?
Absolutely. It's a great, that's where we get creative. So if you have policy in your practice, wherever you are, lean into the policy, lean on it and say, hey, listen, as part of our policy, we can't have you here for the exam or like this piece of the exam. Lean in on it if you have it. If you don't have that piece of the policy, you can, make something up, right? So, with I have young kids, so I'm always like thinking about pediatrics, but with pediatricians, I always tell pediatricians, use the hearing test, because you can't bring kids and parents into the hearing test because then parents give the kids the answers, right? So use something like that. Oh, we have to go, you know what? We have to go into this other room to do like, oh, we got to use a special blood pressure machine. It's in the other room. You know what? You sit here. We'll be back in like 2 minutes. It's no big deal. We'll be right back. Make up a reason. You don't have to do you don't have to do the hearing test. You don't have to do the blood pressure thing. Stick the person in another room and then say, hey, listen, I noticed something and I just wanted to check and make sure you're okay. Now, the danger in that is that either they're going to disclose to you, which is great because that means they trust you, or they're going to be ticked at you. In which case, then you say, well, I'm really sorry that, I saw that, but it's part of my job to notice things like that. And I'm really, really glad you're safe. And I wanted to let you know, if you're ever not safe, that this is a safe place you can talk about it. So get creative about separating if you can.
All right, next is.
And use the follow-up. The follow-up is the piece. If you can't get them away, if you can't separate, if somebody is like the interpreter, use the follow-up. Make that phone call afterwards and say, hey, listen, I just wanted to make sure you understood your medications appropriately. And while I have you, can I ask you about this?
Okay, good, thank you. And then what are some signs of domestic violence that may not be obvious in older adults?
I think when you listen to older adults, what I think you want to listen for is the minimizing of behavior. So again, it's questions about who are the support networks in their life. So who's supporting you? Do you have kids? Do you have friends? Do you feel like you have your basic needs met? and then listening for excuses and minimizing. Oh, well, it's not that big of a deal. I don't want to burden my kids, or I don't, no, this isn't the right fit for me. So you want to really listen to those dismissive comments and dig more into that. I think anytime somebody just switches a subject to on a dime and like literally doesn't answer the question that you've asked them, that's also a good indication that something is happening. It doesn't mean like put the spotlight on them and like drill into there. It means let it go and then maybe circle back. Oh, I just wanted to ask you again, Laura, I asked you this. I don't think I got a clear answer. Can I ask you this again? Circle back.
Right. One of the things I picked up on from your presentation was about the anger, and then that cycle with the honeymoon period and then the tensions building. So I think I would start to listen more for the anger. Oh, he's only angry once in a while, or it's only once in a while. So
once in a while.
Okay.
And asking about pattern, like, has this ever happened before? Do you remember what the circumstances were last time it happened? Or if they're not telling you about a specific situation, if they seem, emotional, or they seem like not themselves, asking about like, how are you feeling today? Where does this come from? Do you ever remember feeling like this before? When was the last time you felt this way? What was happening when you felt this way last time? That's going to get you back to that pattern of behavior, right? And might cycle back to childhood too. Does this remind you of anything like, from your childhood or from previous relationships, or, raising your kids? Is there something in there that is triggering this?
Great questions. So in the chat, we have this one from Elizabeth. She says, what's the difference between contacting Willow and APS when we are confronted with a patient where we suspect abuse?
I don't know Adult Protective Services. So,
yes.
Adult Protective Services is like CPS, right? That's a legal obligation, that's mandated reporting. Willow is just a resource. So we're here to help and support. So when you're connecting somebody with us, it's a service that they can choose to engage in. When you're contacting Adult Protective Services or Child Protective Services, that's a legal obligation because something is happening that you are a mandated reporter to have to report. I also see from Beth too that Willow of Hope is a good resource for trauma-informed care. Willow of Hope, I love you so much. They do such amazing work in trauma-informed care, and with that mindset, they are amazing resources. I'm glad that people from Willow are on today. We love you.
So I don't see any more questions. The Q&A is empty, the chat is empty, and we are just about out of time. So you can always give people an extra 4 minutes back to their day. And Beth says they did a workshop for us at the School of Nursing, and they were awesome for Willow.
They're so great. Yeah. I'll just offer too, since, I'm on here, but that this is a free service too. We do workshops like this all the time in literally every setting you can think of, pre and post COVID, virtual and in person. So if there's anybody on here who wants to learn more or wants to take a deeper dive into something, we're more than happy to, create the curriculum and create a training that is tailored to the needs of whatever your group is. So we're happy to do this. This is a free service.
This was wonderful, so comprehensive, just your examples all hit home. So this was fantastic. Thank you so much. And you've gotten a lot of thank yous and great jobs in chat. So if you're still with us, go ahead.
I was just going to say, please remember to take care of yourself today, please, because some of this stuff can bubble up on you. So reach out to us if you need help and support. Use your EAP, use the resources that are available to you, and take care of each other too.
Very good advice. So thanks everyone for being here. And we have 2 more webinars in the session. I will be emailing out, actually, when you close out of the webinar, the evaluation will show up. So please fill that out for us. That gives us plenty of feedback on our current speakers and what you'd like to see in the future. And then we have 2 more webinars in the series. So we will see you next month and then again in June. So everyone take care. And Lisa, thank you again so much. This was wonderful. And everyone have a great day.
Have a great day.
Thanks. Bye-bye.